So welcome back. I'm Angelo Sinopoli, one of the co-chairs of PTAC. I'm pleased to welcome three experts who have experience in leveraging payment features to encourage some of the innovations that we've been discussing today. You can find their full biographies posted on the ASPE PTAC website along with their overview slides. At this time, I ask our presenters to go ahead and turn on your videos if you haven't already done so. I'll briefly introduce our guests and then give each presenter time to share their perspective on the topic. After all three presentations, our committee members will have plenty of time to ask questions. First, we have Dr. Thomas Sequist, Chief Medical Officer at Mass General Brigham. Tom, welcome, and you can start.
Oh, great. Thanks so much. So I'll just take a brief minute just to give a little bit about my background so you can understand where my perspective is coming from. So I am the Chief Medical Officer at Mass General Brigham, which is a 12-hospital system here in Massachusetts and New Hampshire. In that role, I oversee quality for our system, patient experience, equity, all of the topics that we're here to discuss today. I've also had a 20-year career as a health services researcher and have done a lot of research into the science of quality measurement. And so hopefully what I'm going to be able to do is give you some of my perspectives of 20 years of working in a delivery system, overseeing population health programs and hospital quality programs during that time, and seeing the evolution of a lot of the important work that has happened in our field. So let me just start off with, and you'll see my slides tend to be a little bit less dense, and because I just am hopeful to share with you some important concepts, at least important from my perspective, and I'm going to give a heavy delivery system perspective on this. So the first question in the space of quality is, what are we hoping to achieve? We measure quality for the primary purpose of improving. That should always be our goal. We have secondary goals of measuring quality to ensure accountability, to help patients and providers make choices around care as well. But our ultimate sort of North Star should always be, we're trying to make care better. In how I think of defining quality is that we are trying to do really four things. We're trying to achieve the best outcomes possible. That's not just survival, but that's functional status, physical functional status, and emotional well-being. The second thing we're trying to do is ultimately deliver the best experience to patients. That includes service excellence, but also respect, dignity, and I think increasingly recognize doing that through a lens of empathy, which sometimes can be lacking in a very busy and stressful care environment. And then lastly, equity in everything that we do, whether it's in the services that we provide, in the way we communicate with people, and ensuring that we are avoiding and fighting against structural racism in healthcare. Finally, we are trying to do all of this with as little waste as possible. The challenge really in quality, though, has been how good of a job have we done in achieving this? I think one of the issues is we think about quality measurement, pay for performance programs, and financial incentive programs, which include value-based purchasing programs and total cost of care programs, is how have we prioritized the things that you see here on this slide? So have we put first and foremost the notion that we are going to improve patient outcomes through all of the designs of programs that we have? Are we then going to deliver the best experience possible and ensure equity in everything? I think what we've often done, if we can go to the next slide, is we have probably done approach that work around outcomes, around experience, around equity, and in cost control. We've probably approached those things through separate pillars. And that's been a challenge, as I'll talk a little bit more about. So ultimately, over the past 20 years, what have we really achieved? Slower than we would like improvements in the translation of evidence-based care for those conditions, especially those conditions that cause the most morbidity and mortality. So when we think about cardiovascular disease, cardiometabolic disease, and now increasingly new pandemics like the substance use disorder pandemic that's swept across the country. The second is that we've had limited transitions to a high-functioning service industry. So when we think about whether or not patients feel that they get a coordinated care experience, that they understand the communication that is happening to them with them, do they feel empathy in the messaging that's delivered to them? And ultimately, can they at a base level access the care that we are providing across our delivery systems? I think across the country, we've had a limited transition to this focus on service. And then lastly, and I think is actually one of the most important things that we could all talk about when we develop quality measurement programs and incentive programs through CMS and other payers, is that we have seen, despite probably now 30 years of research in health inequities, we have seen persistent and now even worsening health inequities. And we don't need to focus only on health inequities that we saw emerge as a result of the COVID pandemic. And we saw obviously horrific inequities come out through the result of the COVID pandemic. We also see worsening inequities across the board, whether it's in trainees and development of physician professionals and nursing professionals, right? We are not seeing gains in the diversity of our workforce, but we're also seeing worsening inequities in cardiovascular outcomes and other important outcomes. So, and total cost of care is very, very important for us to have a functioning healthcare system, obviously, and to be able to achieve the goals that we want to achieve. But one of the things that we need to think about is that, like I said before, these goals that we have around outcomes, experience, equity, and total cost of care, they need to be aligned and worked on in a collaborative manner. I think when you get down to the level of the health system, you will find that any ACO or integrated delivery system or hospital network system or ambulatory multi-specialty physician group practice will find themselves with multiple competing priorities. If you are an ACO participating in multiple of the CMS programs or commercial payer programs, you will find yourself focused on at once home hospital metrics and rehabilitation metrics, some programs in the hospital quality space that are disease specific, some in the ambulatory space that are more holistic around episodes of care. And the priorities that get sort of brought upon us in these settings can make it hard to sort of coordinate the work that you're doing. I think also, if we are truly to focus on an outcomes orientation for our delivery system work, what we find is that you are often focused on financial planning for that year in a pay-for-performance framework that really is for that year, while the clinical outcomes goals that we hope to achieve may be 5 years on the horizon. So if we are hoping to reduce overall cardiovascular morbidity and mortality, or let's say just say mortality at the population level, that is a 5-year plus endeavor. However, the finances built around pay-for-performance programs actually don't support that long of a timeline and can make it challenging to really bring together our financial goals and our clinical outcomes goals. So ultimately, then what happens on the ground is you just have confusion around the direction that we should be following around incentive programs. That remains one of the challenges. It's not a new challenge. It's related to the common challenge that you will hear that there are many, many different quality measures, but it's not just that there are many quality measures which can be managed, although there are some expenses associated with that. What's the bigger challenge is the alignment and the coordination of them. And how do we as frontline clinical teams sort of spend our day, and frontline management teams, how do we spend our day? So I just want to kind of re-emphasize something that I'm sure that everyone has seen before, which is how we talk about quality. So if we take a very traditional view of quality, we might break it down in 2 zones. One would just be content areas. That would be like the traditional sort of IOM model from the late 90s, which would say effectiveness and timeliness and safety and equity and experience and efficiency. Those are the sort of the content areas. And then there's this other way of thinking about quality around structure, process, and outcome. I put up the structure, process, and outcome because I think sometimes in our models of quality measures, we sort of mix up the concepts of the content that we're talking about, whether it be safety or experience, and the model of structure, process, and outcome. When we think about structure, process, and outcome, that the goal that we should really always have in mind is ultimately we should always be building towards improving outcomes in our measures. So when we have structures and processes, we should be developing quality measurement programs that actually lead us down the road towards a better outcome. And I think sometimes we've fallen short of that and we've gotten stuck on the structure and process side. I think, more than 50% of the quality measures in CMS programs these days are actually in the structure and process bucket. And so far fewer of the measures are actually in the outcome bucket, which is actually what our ultimate goal is. Next slide. So how do I think we can promote better patient outcomes in population-based total cost of care programs over value-based programs? So the first point I was making on the prior slide, we really should be strongly evaluating programs for inclusion of outcome measures over process measures and structure measures. That doesn't mean that any given year, there always need to be more outcome measures than process and structure, but we should be moving structure and process measures along a pathway that always leads to outcome measures. The second thing we should be focused on is bringing clarity around what is a quality measure versus what is a utilization or an access measure. We increasingly, especially if we want to control total cost of care, and we are incentivizing physicians, physician group practices, or even hospitals, we shouldn't confuse the notion of complete utilization metrics with quality and outcomes measures. So the third thing I would say is that we want to start to synchronize and be inclusive for hospital and ambulatory metrics. We have to really start to understand that the hospital-based value-based purchasing program from CMS actually does have direct implications for our ambulatory HEDIS metrics, and make sure that we are syncing those programs together. And then lastly, we have a much longer history of primary care quality measures than we do ambulatory specialty care, yet most ambulatory care is delivered in the specialty space. We have to be able to understand how to move the dial further down the path for specialty care in terms of measuring outcomes in the ambulatory specialty area. So if we go to the next slide, how do we promote experience in total cost of care programs? I think we have to really start to value communication, coordination, and empathy as outcomes unto themselves. They don't, these patient experience measures, whether we're talking about HCAHPS measures or other versions of patient experience measures, they don't have to specifically link to a clinical outcome to be valued. A patient's experience and service actually is important unto itself. We should, in that vein, then be focusing on more objective reports of care over subjective ratings of care. So rather than saying, how would you rate this hospital 1 through 10, focus on the actual activities that happened in the hospital from a patient report, like were your medications explained to you at discharge. And lastly, how to promote equity in total cost of care. We have to really, because that gap is growing, despite all the literature around this space, we have to really start to obsess over closing that equity gap in outcomes. That means really set it as the highest priority in all of our performance measurement programs. One of the things that we have to avoid doing in all of our performance measurement programs is implementing programs and then learning 3 years later how big was the inequity that was created by the implementation of the program. We know enough now that we can predict when inequities are going to develop as a result of performance measurement and incentive programs. So we have to really be on top of that in a prospective way. We need better data. We need to understand not just race, ethnicity, and language. We need to understand all the social risk factors that go into predicting clinical outcomes. We need to avoid measures that keep us stuck in that structural space. So measures that focus on things like creating equity improvement plans are not the way that we are going to move the needle for really what I consider to be an urgent crisis in public health, which is this equity gap, and in particular, the gap created by structural racism across our healthcare systems. So we really need to avoid those structural measures or getting stuck in those structural measures. And then lastly, being thoughtful about risk adjustment. And especially as it relates to reimbursement and outcomes. I won't go into all of the details on this, but it's really important for us to understand when we take race, when we take some of the risk factors, social risk factors that we can use as surrogates in the CMS data, whether it's dual eligibility or other sort of CDC designated area risk indices, we have to understand that those levels of risk adjustment and when we try to apply risk adjustment in that setting, all that does is sort of bake in and standardize the current inequities that we have. If we're going to really address inequities in this space and do it through risk adjustment, we have to acknowledge that we need more resources than are currently being delivered to even the best hospital systems right now that care for, let's say, Black and underserved populations. So we have to be much more thoughtful about that if we're going to take on equity overall. Thank you.
Thank you. That was great information. I appreciate all of that. Next, we will have Dr. David Meltzer, who is the chief of the section of hospital medicine, Director at the Center for Health and Social Sciences, and Chair of the Committee on Clinical and Translational Science at the University of Chicago, and Fanny L. Pritzker Professor of Medicine, Department of Medicine, University of Chicago Harris School of Public Policy, and the Department of Economics, and a previous submitter to the Comprehensive Care Physician Payment Model CCP-PM proposal. David?
Great. Thank you so much for allowing me to present. I really appreciate the opportunity from PTAC and ASPE. Just to say a little more about my background before I jump into the topic of measuring the desired characteristics of outcomes for population-based total cost of care models. By way of introduction, I'm a practicing general internist, both a primary care physician and a hospitalist. I want to take this opportunity to thank Dr. Burston and Dr. Schneider for being my clinic preceptor and one of my residents way back when. I certainly wouldn't still be practicing after all these years were it not for your teaching. I'm also a PhD in economics. And I'm a professor here at the University of Chicago, where I run our section of hospital medicine. My research focus over the years, you can go to the next slide. My research over many years has really focused on the value of medical specialization. I used the inpatient general medicine services at the University of Chicago as an opportunity to study the effects of specialization with the development originally of hospitalists. I studied the effects of hospitalists on outcomes and found really limited evidence that hospitalists made a big difference. And this led me to wonder why hospitalists had grown if they really weren't so much better. And I came to the conclusion that a lot of this was because of the changing nature of primary care with falling hospital volumes for traditional general internists, so that it just no longer made clinical sense for them to block their mornings to see patients in the hospital. But I also realized that this caused a compromise in the doctor-patient relationship, particularly for patients at high risk of hospitalization. And this led me to develop the Comprehensive Care Physician Model, or CCP model, in which primary care physicians focus their practice on patients at increased risk of hospitalization so they can care for them both in and out of the hospital. And I studied this through several randomized trials at the University of Chicago Medicine, and the results of these will inform a lot of my comments today. And I'll just point out the University of Chicago exists on the south side of Chicago. It's actually a very competitive healthcare market, and one that serves a lot of very socioeconomically vulnerable populations. And so it's an area where sort of success of these models is maybe particularly challenging and important. Next slide. So let me talk a little bit about the results of our CCP studies. The first of these was a CMMI-funded 2,000-person randomized trial that compared CCP to standard care with different doctors in and out of the hospital within Medicare patients at the University of Chicago who were at high risk of hospitalization. We found really striking results. In terms of HCAP scores, the rating of the primary care doctor increased from the 20th percentile at baseline when people entered the study to the 95th percentile for CCP. It actually increased also to the 80th percentile for standard care, because we got these folks who weren't happy with their doctors, a new doctor, but a different one in and out of the hospital. In terms of utilization, the key finding really was a 15% decrease in hospitalization. This was evident in self-reported data, which is what I have here. We've also analyzed it in Medicare claims now, and what that shows is same pattern overall of 15% decrease, but actually a 30% reduction in non-dual eligibles, so patients just with Medicare and not Medicaid. And in those with Medicare and Medicaid, the dual eligibles, we saw a 10% decrease, so much smaller and not statistically significant. The reasons behind this smaller decrease in the dual eligibles, I think, are very important for this discussion today. A big part of it is that there was an artifact really due to what turned out to be twofold greater retention of high-risk patients in traditional Medicare compared to managed care in the CCP program as opposed to the standard care arm. And that happened in the context of Illinois' Medicare-Medicaid alignment initiative, where basically the dual eligibles were involuntarily enrolled into managed care, and they could only opt out And the sick patients decided to stay with us because they thought they were getting better care for us. And that was not true really in the standard care arm. So we had sort of adverse selection. I'll come back to that in a minute. The other big reason I think the original program wasn't as successful in duals was the failure to address unmet social need. Now, in 2018, we came to PTAC to propose a per member per month payment model to support the growth of CCP, and it was recommended for limited scale testing. But with primary care first and a variety of other things, that never happened, and of course, COVID. One of the next studies we did really was to develop an intervention to address unmet social need. This was originally funded by the Robert Wood Johnson Foundation. We called it the Comprehensive Care Community and Culture Program, or C4P. It screened, in addition to CCP, it added screening for unmet social needs, a community health worker, and a community-based arts and culture program to activate patients. In our pilot work for this, and now a subsequent PCORI-funded 3,000-person RCT comparing C4P to CCP versus a Partners-like care coordination program, our interim results are showing that C4P dramatically reduces hospitalization for CCP, even for the duals and especially for the least activated patient. So we think this really is an important addition to this to meet the needs of vulnerable patients. Next slide. So in the next few slides, I really want to address sort of the question of the day, which is these performance measures for population-based total cost of care models. I'm of the belief that measuring both outcomes and care processes are critical goals for performance measure in these models. If we want to improve outcomes, including controlling costs and patient satisfaction, we have to measure them if we wish to improve them. I do wish to highlight, though, some reasons for concern. There may be instances in which improving measures for populations most easily accomplished by sacrificing them for some subgroups for whom it's much harder to move things. One of the particularly extreme versions of this is that in many instances, improving measured outcomes can be more readily accomplished by avoiding high risk or high cost patients than improving outcomes for the ones you keep in the program. This is particularly true for costs, where a handful of people often account for the majority of costs, and avoiding them is far easier than doing the job we should be doing of actually addressing their problems. I also want to highlight that linking performance measures to payment can have some complicated consequences. In fact, disincentivizing measure improvement. We've seen this in patient experience measures, where, for example, we get rid of the top category of excellent and pool it with very good. And that's considered a better measure than really looking at excellent experience. We've seen in our own institution that the harder we work to capture outcomes for vulnerable populations, it does not improve our outcome measures. And I think these are the wrong incentives. I also want to say that I think this idea that population-based total cost of care will improve care or reduce costs has to be considered a hypothesis. There are alternatives, including real fee-for-service reform, promoting competition. Not that these are always mutually exclusive, but I think it's really important to be open as we think about this. I also think it's really critical in thinking about how we measure care as we think about the goals of performance measurement and why we're doing it. I think measuring care is important as a mechanism to temper overemphasis on outcomes and incentives for gaming the system, so sort of process. It's important for testing hypotheses about how to improve care. I also think measuring process of care is critical for increasing the likelihood that practices that actually improve outcomes are followed. So when you pay for care coordination or you pay for defragmentation, you clearly direct people towards that. And I want to emphasize that we may wish to pay for process as opposed to paying for outcomes, depending on our confidence in the validity of each measure. What are some of the other goals of performance measures and what strategies are effective? It's critical to measure these effects in subgroups, especially the vulnerable ones, given program design, for example, high-cost patients, where there's incentive to skimp on care. Issues of causal inference are critical in evaluation. I think we do far too few RCTs, far too few demonstration projects with robust controls. I think we need to really look for clean, natural experiments. And I think it's critical to try to avoid programmatic interference. Our experience with MMMI in the context of the Innovation Award points to these problems. It's also important in performance measure to think about mitigating the risks in payment models, whether there are selection issues, as I've highlighted, or rewarding suboptimal processes. I'll point out that when we pay for care coordination, we, in a sense, reward people for creating fragmented care that requires coordination. And then finally, I think it is important to advance the science of patient-centered care and measurement. Goal attainment is a great example of a measure where much more is probably needed to really make it practical. Next slide. A couple of other things really to highlight as important issues to address in measuring outcomes. I think it's measuring patient experience, population health, and cost. There are a number of overall concerns that are critical. It's critical to measure all these outcomes in vulnerable subgroups defined by medical, social, and payment-based risk factors. And I think important to stratify those by market structure because there are very different outcomes in different markets depending on the structure of competition. I think outcomes like how well is a program doing in retaining vulnerable subgroups, what are the outcomes of people who transition out of programs would be really important areas. And then finally, thinking about outcomes of the population. What is the relevant population? Is it people enrolled in your plan? Is it a county? How do we make people accountable for care that they have very little to do with if we make the populations broader? There are also some domain-specific concerns that I think are critical. In patient experience, we can have minimal measures like HCAHPS measures and patient experience simple measures. And even there, we have issues like top coding. And then we have aspirational things like goal attainment, where measures are even harder. In population health outcomes, we know it's hard to move general health measures, and this makes it very tempting to focus more on disease-specific measures. And there are only so many of those we can have. I think prioritizing those linked to identifiable clinical opportunities, one example being mental health, may be some very important ones. And then finally, in costs, we can't just think about Medicare A and B or total cost to Medicare, including managed care. We have to think about Medicaid. We have to think about the hidden costs to stakeholders, including managed care organizations and providers, and to non-medical stakeholders, the social service delivery system and jails and housing and so on. And then finally, and by no means least importantly, I think it's really critical to do more to measure the work life of healthcare providers. What are the quality and effects on the relationships that these providers have with patients, with their colleagues, with provider organizations, with payers, and with policymakers? We've seen huge rates of burnout. And when we see that burnout, we lose providers who we need, and we sacrifice continuity of care, which seems to be a key driver in positive patient experience. So let me stop there. Thanks.
Thank you, David. It's fascinating insights. Lastly, we have Dr. Franklin Gaylis, who is Chief Scientific Officer at Genesis Healthcare Partners, Executive Medical Director at Unio Health Partners, and Voluntary Professor of Urology at University of California, San Diego. Franklin?
Thank you so much, and I greatly appreciate the opportunity to share our experience implementing a pay-for-performance quality improvement payment model, which would seem so easy yet so difficult. I've had a deep interest in quality improvement for more than 30 years, and it's a pleasure to be part of this presentation. Next slide, please. Some background: Genesis Healthcare Partners, the group within which I work, has been in operation for 13 years, has 110 physicians located throughout California, has experience with both two ACO models and the novel pay-for-performance pilot, which I'll delve into in more detail. The goals of our quality improvement intervention was first to create a cost-effective care best practice to improve the treatment of patients with low-risk prostate cancer, develop 4 meaningful performance measures, and 2 interventions which were implemented. Firstly, provide feedback to our providers, our physicians, audit and feedback, which we call transparency, and a pay-for-performance model. The implications are firstly identifying meaningful specialty-related performance measures, and obviously this is a urology-specific specialty model, and explore the possibility of hybrid models between organization level and provider level measures. Next slide. Prostate cancer is the most common non-skin cancer in men in the United States, and it's the second leading cause of cancer deaths. And the overtreatment of low-risk prostate cancer, which we refer to as indolent or slow-growing disease, tends to do more harm than good. And despite recommendations to adopt conservative management, which is active surveillance or watchful waiting, for more than 20 years, both the adoption and the quality of active surveillance for low-risk prostate cancer remain suboptimal. And the disease disproportionately affects Black men who tend to present with more aggressive disease and have higher mortality rates compared to white men. Black men tend to experience less access to prostate cancer treatment, longer delays between diagnosis and treatment. And some of the factors responsible include mistrust of the healthcare system, poor physician-patient communication, lack of patient knowledge of the disease and treatment. And it's an expensive disease to manage. The cost estimate for 2020 was $18.53 billion, with an additional $8.4 billion loss in productivity between their men and their spouses. Next slide. As this cartoon depicts, we still have an enormous challenge in implementing evidence-based knowledge into routine clinical practice, as estimated 17 years. And the field of implementation science seeks to speed things up, and our project reflects implementation science and approach. Next slide. And this challenge has been recognized by our urology specialty, as noted in this editorial, that it takes historically 17 years to adopt proven interventions, and that research increasingly shows that our best treatment advances may not be implemented effectively in diverse settings and populations, and this results in inequitable access and effectiveness of care, and that we urologists and physicians in general have major problems with implementation. Next slide. This slide serves to show a chronology of our group, Genesis Healthcare Partners in Quality Improvement Interventions. Back in 2011, we formed this large group of 25 physicians, and one of our initial objectives was to mitigate the overtreatment of low-risk prostate cancer. And in 2011 through 2012, we implemented a best practice which included passive education, and this resulted in minimal improvement. In 2013, we implemented an anonymized physician audit and feedback dashboard, which resulted in significant improvement in the adoption of active surveillance for low-risk disease. And then if we fast forward to 2022, through a collaborative with the Prostate Cancer Active Surveillance Project and United Healthcare, we implemented 2 interventions. First, a transparent physician audit and feedback, and secondly, a pay-for-performance value-based model, resulting in even more improvement. Next. This slide shows the dashboard that we used more than 10 years ago. It was published in the journal Urology. And you can see on the left-hand column, there's a physician listed, but in an anonymized fashion. And we created a benchmarks, which you can see in the key below, poor, suboptimal, and optimal at the time. And the first column reflects our adoption of conservative management, which was, if you look at the bottom row, 32% between 2011 and 12. That's 13 years ago. We then implemented the dashboard shared physician performance with our respective physicians, and one can see that between the second and third years, there was a dramatic improvement from 39 to 58%. Between the first and second year, passive education was used with minimal improvement, but when physicians were compared to each other with audit and feedback, that resulted in a dramatic improvement. In the next slide. Fast forward to 2022, this slide reflects the 4 quality measures that we developed in collaboration with the PCASP and United Healthcare. The first was documentation, which may be considered a structured measure, where EHR embedded templates or structured notes were placed, and this prompted physicians to directly risk stratify and document how they were caring for patients to mitigate the need to do retrospective chart analysis, which is laborious. We set a benchmark of 90%. The second measure was conservative management or observational management of men with low-risk disease, and we set the benchmark there at 75%. The last two measures, confirmatory PSA testing, more than 2 PSA tests per year, and a confirmatory repeat biopsy, which is a second biopsy after the initial biopsy to ensure we have the right diagnosis to put a patient on conservative active surveillance management. We set the benchmarks for the latter two at 75%. I should note that Measure 1 and Measure 2 were EHR-based primary clinical data retrieved, and Measure 3 and 4 were based on claims data. One should also note that the payment incentive was determined by the entire group meeting all 4 quality measures and was paid to the group, not to the individual physicians. Next slide. And these are some of our data. This is for Measure 2, the adoption of conservative management for low-risk prostate cancer. One can see in the rectangle at the bottom the total for all 3 groups within our large group, 83% adoption, which is a dramatic and heartening improvement compared to past performance and also compared to national standards, which are about 50 to 60% according to published data. In the next slide, we look in a little more detail at Measure 1, which is the documentation according to payer type. And you can see in the right-hand top rectangle, we had excellent adherence in the United Healthcare patients who were both eligible or not eligible for the P4P program compared to other payer patients. And that was a result of additional interventions, which included, as I've mentioned in the left top of the box, meeting with office managers, reminders to physicians with outstanding incompleted charts, calling physicians or emailing, and monitoring the data. It was a laborious task, but in order to meet the measures, we had to do this extra work. And as I mentioned in the last slide, we had an 83% adoption overall for all patients, irrespective of payer. And one can see the 2 rectangles at the bottom on the right-hand side reflect only United Healthcare patients who were eligible or not eligible for P4P. And if you do the math, only 12% of the entire cohort, 12%, were eligible for the P4P program, yet we saw a significant improvement in adoption of active surveillance. Next slide, please. Next slide. We decided to go back to get a baseline in 2019 so we could compare all 3 groups that had been more recently introduced to the Genesis group. And our baseline was 65.5% adoption for low-risk disease, which is Measure 2 in 2019. It improved dramatically to 83% in 2022. And in 2023, last year, we were at 86%. The pilot project ended last year in 2023, and our preliminary data, because these are EHR-based data sets, for 2024, we're at 92%. So the trend continues, which is gratifying. Next slide. I'd just like to pivot to the cost of implementation and some of the savings. And some of these matters have been addressed in earlier presentations I heard. It's an expensive effort and endeavor to implement these data retrieval efforts. And automated electronic data capture and an analytics system required a more than $220,000 build, which included the creation of templates in the EHR, the data capture process implementation, refreshing of dashboards. The savings potential is significant because the cost of initial radical treatment for low-risk prostate cancer, which is radical prostatectomy or radiation, compared to conservative management is 4 to 5 times greater. And increasing the rate of conservative management from what I just showed as our baseline of 65.5% to our 83%, which we observed in 2022, would reduce the average 3-year cost per patient by more than 25%. And given that about 300,000 men are diagnosed with prostate cancer in the United States each year, of whom 60 to 75,000 have low-risk disease, the potential cost savings to payers with conservative management is considerable, estimated to be between $150 to $200 million over 3 years. However, this is nuanced because we know with time, more men will progress and unfortunately convert to active treatment. Next slide. Addressing some of the challenges to implementation, firstly, and has been addressed on numerous previous presentations, relevance. The measures have to be relevant to our colleagues. The ease of implementation, we need to minimize physician effort. We just heard the last speaker talk about burnout. We can't burden our physicians with more effort. And that's why we created templates and structured notes to create structured data sources for the data. And changing group culture and buy-in requires leadership to drive change. Defining these 4 measures that I just shared took 2 years to agree on the measures and thresholds with internationally reputable prostate cancer researchers. The reporting mechanism required significant IT investment to capture, measure, and report, and this was quite costly. Next slide. I want to just pivot for a moment, and I apologize for this busy slide. However, we believe that data speaks of this slide volumes and begs the question, what quality measures are relevant to urology practice? And these data reflect what's been reported by urologists in MIPS. And if you just focus in the yellow highlighted top in the rectangle, music 4, which is equivalent to our measure 2, which is active surveillance or watchful waiting for low-risk prostate cancer, was reported by 2 urologists. In contrast, if we look at the bottom rectangle, the cross-cutting measures controlling high blood pressure, tobacco use screening, body mass index measurement screening, look at the numbers reported by 5,000 urologists, 3,000, more than 1,000. These are easier to report, but you have to ask the question, do they reflect the quality of care being provided by a urologist specialist? Next slide. And some final thoughts. The implementation of a quality improvement program using the specific interventions which I shared, transparency, audit and feedback, as well as a payment incentive has great potential. What we experienced was scaling these programs is a challenge. Only one group participated in the UHC program. Broad acceptance by other payers was a challenge. Only United Healthcare participated. 5 other large payers were invited but elected not to participate. We strongly recommend that the government should be participating and taking the lead and encourage the private payers to follow suit. The programs that we establish need to be practical, relevant, and easy to implement. And the funding needs to be accessed to implement such programs, which is critical to the startup expenses which we experience. And as I've heard previously, based on what we saw, perhaps we should be paying for reporting, as this is most challenging and costly. And measuring and reporting often leads to the result known as the Hawthorne effect. That is, when people are being monitored, their work product tends to improve. Thank you for your attention.
Thank you, and thanks to all the presenters today. So PTAC members, please feel free to ask questions throughout the conversations, and just remember to flip your name tag up, or Josh, since you're on Zoom, if you can just raise your hand in Zoom if you have questions as we progress. So I'll start out with the first question. So what do we want to measure? And total cost of care models that will ultimately lead to the quadruple aim, which includes outcomes, experience, and how care is actually provided. So if we could start out with Franklin.
Well, I think it needs to be disease specific. And in our example, measuring the appropriate care for low-risk prostate cancer, we wanted to mitigate the harms of over-treating prostate cancer, and therefore we chose active surveillance or watchful waiting as conservative management. With regard to patient experience, we have employed the Radar 8 system, which includes the Net Promoter Score. So we routinely measure patient experience. The cost I commented on, there's dramatic, significant cost benefits to what we're doing. But I think there's a caveat that's important to note. And a similar model was presented to the PTAC several years ago. And one of the issues was, how do you protect patients? And I think tracking these patients to make sure that if they progress on active surveillance conservative management, we capture them in a timely fashion that we can still provide them curative therapy. So I think some of those are essential items to this particular model.
Thank you. How about David?
I think we want to measure many things. We don't want to just measure outcomes. I appreciated Tom's comment that sort of getting to outcomes is a great thing. But I think that path from structure to process to outcomes, I think it's extremely important along the way that we look at those. And one of the challenges, of course, is there are many steps along the way and we can't measure them all. And I'm appreciative of the idea that disease-specific measures are often sort of cleaner but they're narrow. And so I think we need to be thinking carefully about what are the cross-cutting processes that really drive care and that are relevant across multiple diseases and multiple outcomes. And, they include, to me, things like relationships with providers, whether people are having regular visits in primary care, whether they're avoiding hospitalization, those sorts of things. And so I'd like to see us have a balanced approach that's driven by an understanding of the risks of gaming and the processes that can drive improved outcomes as well as measuring outcomes.
Thank you for that. Franklin?
I think I just commented.
I'm sorry, Thomas?
Did you want me to go next, or?
Yes.
Okay. Yeah, just listening to this, I think this is a hard question, right? And I think you sort of have this, I think we're sort of stuck between two choices, I think. So one is what David is saying is, pick a broad-based kind of structural or even better, a process measure that we think will impact care across the board, and trust in that that's going to improve the outcomes that we're all desiring. If you take like more of the outcomes approach, what I would say is, so that's one option. Another option is to take an outcomes approach, but then how do you do want to avoid it. You're only looking at a couple conditions and you're not really looking at the health of the whole population. One of the ways to think about that is to be really specific about what contributes to the biggest morbidity and mortality problems across your population that you're focused on, and really focus your measurement in that space. And it may be that focusing on that gets you to, 50% or 60% of the total morbidity and mortality in population. But if you will have optimized care for that percentage, you will have done a lot, like in your population-based care model. I don't think there's a right answer here between those two choices. They're just different approaches. What I think is not the right answer from a delivery system standpoint is having two different programs taking two different approaches. That's really challenging when you're on the ground and you're being sort of asked to do one thing, which is focus on these sort of broad-based process and structural measures, and then from a different program, given very targeted outcomes for a very specific disease. That's really hard.
Thank you. So I think the next question digs a little deeper into what we just discussed, and we've heard this morning a lot about a balanced portfolio approach of a mixture of what we're measuring. And so the question is, what is the appropriate mixture of outcome, patient experience, and process measures to directly measure system change, and how organizations provide care, with the thought in the background of there's been concern of too many metrics out there, too many things to measure, too expensive, too much administrative burden. So how would you all approach that question in terms of prioritizing what's important? And so we'll start out with David this time.
Sure. I think it comes down to the question of kind of why we're measuring these things, and I highlighted a couple in my remarks to temper overemphasis on outcomes and the potential to game the system. In those instances where we think gaming is particular at risk, I think we want to go at least partially make sure we've got the process along with it. To test hypotheses about how to improve care. If we are not sure that a process is important, it may be more important to measure it in order to understand if it really does correlate with outcomes. To drive change, to make sure that care practices that we do think improve outcomes are being followed. No better way than to pay for them. And I think ultimately, as we balance these, we need to look at the confidence we have in the outcomes measures and their value, and those that we have in the process measures, and overweight those things we're more confident in, and underweight those probably we're not. I think that's how I would put together a balanced portfolio.
Okay, thank you. Thomas?
Yeah, I don't know that there's like a number, like there's a pie chart that shows that it's, 1/3 this, 1/4 this, and 1/4 that. I don't think that that's the answer here. What I would suggest though is when as I look at like our programs over the past couple of decades, I just going back to one of the points I made earlier, I just worry that we get stuck in the structure and process realm, and we're often not, and we really, really optimize those. And you can see some structure and particular process measures that have gotten close to 100%, let's say like in the HEDIS space, and yet we're not, preventing cardiovascular death at the, to the same degree of improvement that we're seeing in those process measures. And so my only sort of advice here would be, it's not that there has to be a certain percentage of them measures in a portfolio that are outcomes versus process, but we have to force those process measures to be pointing towards an outcome measure. And if they're not pointing towards an outcome measure over time, I think we're not like following the model correctly of quality improvement. And I think that's that. And then that leads to, people just hyper focusing on process measures. And I don't know if they're not really gaming it, but you can, process measures can be made to improve in such a way that it doesn't actually improve the outcome measure that they were intended to be linked to. I just think it's really important for us to always keep in mind, what is the link that we're hoping to achieve between your process measure we have and the health status that we're hoping to achieve, and making sure that we're validating that link repeatedly over time.
That was great. Thank you. Franklin?
Yeah, I just want to make the point that I don't think there's a one-size-fits-all. And I think we have to recognize that, speaking as a specialist, a surgical specialist in urology compared to primary care, what's relevant and important to the patients that we're treating is very different. And, within our group, we've got multiple subspecialists, even with urology. So with a physician who's treating female urinary incontinence as a specialty, there needs to be certain validated questionnaires to measure the outcome of their treatments. An oncologist, a surgical oncologist, will be looking at surgical outcomes and, perhaps 30-day readmission, morbidity, mortality. So I think this is where we've had challenges. I've been in the field for over 30 years, and still we do not have standardized measures that are uniformly applied to urology. And that's why you see a lot of cross-cutting measures being reported on. Process measures, as been discussed in our example of active surveillance, they're important and they do lead to measuring an outcome. We want to make sure, for example, a patient on active surveillance remains on active surveillance and doesn't have progression of their cancer and dies from it because they weren't actively and appropriately monitored or surveilled. And that's where, like the 2 PSAs, a confirmatory biopsy, perhaps an MRI, these have to be customized. So these process measures do lead to hopefully better outcomes. I'll stop there. Thanks.
Thank you so much for all those comments. So So as we move more and more toward a total cost of care model and even global payments, how do the performance measurements that we're measuring today differ in the value-based purchasing programs from what it needs to be in a total cost of care model? And so I'll start out with Thomas on this one.
Sorry about that. Yeah, I mean, I'm trying to, and I thought about this as we initially talked about this panel, and now having heard everyone's comments, I don't think that it's necessarily so much about the difference between value-based care programs and total cost of care programs in the quality measures. I think it's more of a generic question about what direction do we think quality measurement is going and how can we improve it. I don't want to sound like it's completely broken. It's not. I mean, I think there's been a lot of really great movement in this space over the past couple of decades to improve care. To me, the thing that can improve most in these total cost of care programs is a couple things. One of the things David has said a couple of times, which is really, really important, is to make sure that we're designing them in ways that prevent folks from gaming in a way that would adversely impact underserved populations, whether that's through selection processes or care management processes once they're in your clinical programs. It's just really, really important in any program that starts to look at cost that we have up sort of barriers or guardrails around underserved populations of any form, whether they be folks who don't speak English, folks who have lower incomes or from different racial backgrounds. That's one thing that I think is just really critical. That's been a problem in value-based care programs. It would be a problem in any sort of total cost of care program. So I don't think that's a sort of a difference between those two models, but it's really critical as we move forward in these total cost of care programs that we have that very closely in mind. And then the second thing I would say, sorry, I'm babbling a little bit, but the second thing I would say is that it's just really important that we understand and have alignment for the folks on the ground and the different ways we're being incentivized to improve care. So I think we should choose, from all the things we're talking about, process measures, outcome measures, the links between them, how does service excellence and patient experience fit in? I think it's really important that when the messaging hits the ground level, so an individual hospital or doctor's practice, that we have picked one conceptual sort of approach on quality measurement, so the teams on the ground can actually design their interventions in a way that doesn't feel so chaotic or spread out. Right now, I think there's just different messaging around what's important. Is it structure, process? Is it outcomes? Is it patient experience? How do the cost measure balance? And it's challenging.
Perfect. Thank you. Franklin.
I think the principles of quality measurement, whether it's structure, process, outcomes that we've been discussing extensively, can be applied across, all disciplines, subspecialties. But I think we have to understand that each specialty is very different in what's relevant to their practice, what's relevant to their patient, what's relevant to the physician. And, for example, if we just look at prostate cancer, and we had a few groups participated in the OCM model, the oncology care model, and they had to drop out because things changed, and there was this was treating patients with advanced prostate cancer. And what happened was a lot of the new drugs, which are very expensive, came into development and were available, which hadn't been taken note of in prior experience. And as I've been speaking about, early stage prostate cancer is a very different setup. We've got active surveillance versus surgery versus radiation, whereas in advanced disease, you're talking about very expensive therapeutics like androgen deprivation and chemotherapy and novel agents used in oncology. So I still think one has to dissect it out a little more and become specialty specific as we design these value-based models or total cost of care models.
Thank you. David.
I guess I'd like to highlight that population-based total cost of care models may differ from traditional value-based purchasing programs, both in the population part and in the cost part. So one first question is, what is the population? What are the denominators? in each of those, and how fixed are they, how fluid are they, and how are we dealing with the changing denominators. I would interact that with market structure. In an area where you're the dominant provider and there's very little competition, gaming has a very different character than a market like the one we're in. And then in the total cost of care domain, I really want to point out how important this is, particularly for socially vulnerable populations, where there are a variety of social services where utilization is very much integrally connected with medical utilization. But even for more affluent patients, things like decisions you make in your 50s and 60s about how to manage your prostate cancer may affect the urinary incontinence you have years later, with consequences for your ability to live independently and costs, for example, to Medicaid. And so we really need to think in a more integrated way about these things if we're going to reach this sort of goal of population-based total cost of care. And dealing with both what is the population and what are the costs seem to me critical differences.
Perfect. Thank you. Lauren, you have a question?
Sure. I'm going to ask a follow-on question based on that, and starting with David, but everyone is welcome to answer. I was really intrigued when you were talking about the subgroups that you're seeing in the most vulnerable high-cost populations you're serving. And I'm curious what patterns or archetypes you're seeing in those, who those population subgroups are, and how that's informing what measures you're considering that would advance equity and total cost of care models.
For sure. I can highlight one in particular that sort of speaks volumes. Young Black men with end-stage renal disease. Huge high costs of care, horrible, outcomes far too often come into the program with really serious illness, often very much sort of neglected care, tremendous unmet social needs. And I will tell you that population in our group is about 6% of our total population. And it accounts for an absolutely huge amount of costs, an absolutely huge amount of morbidity, and just screams for attention. I will also point out that alternative payment models, for end-stage renal disease, were very active in this region during the period when our study began. And I think that there were profound incentives for selection. And the other thing I'll say is this is extremely difficult to study. Our RCTs are 1,000 patients per arm, basically. So that's the scale of the RAND health insurance experiment. Our intrinsic underlying variability in some ways is less than the RAND health insurance experiment because the level is so much higher to begin with. We have very few low utilizers. That much said, a handful of people, and I literally mean numbers like this, are enough to drive utilization between arms with selection, enough to matter in a study of that scale. And when I say we don't do enough RCTs, I really mean it, and we don't do enough at scale. And I can't tell you how blessed I feel to have been able to work so many years on such a complicated RCT, because I've learned things that I don't think I honestly ever could have learned in observational studies. And I'm trained as an economist. We love to analyze data like that. But sometimes an RCT is just invaluable.
Tom or Franklin, would you want to comment on that or no?
Well, I'll just comment on what David said about RCTs. I've been part of the PCASP, which is a national consortium of academic and community urologists trying to do an RCT comparing transparency, audit, and feedback to a pay-for-performance model, because we have such a paucity of data. And it's been very difficult to get funding. We've been working on it for 6 years, and we're hoping to submit another PO1 grant in the next coming months. But to David's point, it's critical to understand what implementation science really makes a difference. And just going back to our model, I really think that our physicians, knowing that they're being measured and monitored has driven up appropriate performance of active surveillance adoption versus the financial incentive. But one other point I just want to make is that getting the data is a huge challenge. And I'm in private practice. We're in a community group. We don't have the resources of the Brigham and University of Chicago. These are extremely and exorbitant amounts of money that we've had to invest with no compensation whatsoever to drive a more than $200,000 investment in IT to pull the data. And you can't get the data if you do retrospective analyses because physicians' documentation in the EHR is poor. We can't get clinical stage of disease to risk stratify. So, it's nuanced. There's so many variables, but I think these are all really good points for discussion.
I totally agree with David on that sort of archetype condition with end-stage renal disease. The other area that I would just highlight that is very expensive, but it's spread out amongst a much larger population, but is a challenge in the space of equity, is substance use disorder, housing security, and food security. These things all sort of come together and then end up getting managed in our emergency departments, which is from a total cost of care perspective, but even probably more importantly from a care perspective, not what anyone desires. And I would say that one of the things where we see the greatest inequities actually in our system is not specifically only related to race and income. It's actually related to language. And so when we have patients who don't speak English as their primary language, you are really trying to drive towards complex care management, you really do realize how critical and how just everything is built 99.9% around English across the system. And whether you're running care management programs, whether any kind of program that we're running, it's been very hard to sort of overcome that challenge. So I just point out, I think there are these conditions like end-stage renal disease, super expensive, very high complexity in terms of management. There's this other background set of issues that is contributing to inequity that are very expensive as well. That's been a real challenge for us.
If I could just add something on top of Tom's comment, just to be clear, these young men with end-stage renal disease I'm talking about, the vast majority of them are dual eligible, tremendous unmet social need. So these populations overlap profoundly, at least in our environment.
And if I may make a comment regarding the inequity in the Black population, which we've seen, the men tend to present with much more advanced, more aggressive disease. And there may be a biological component, which we think, but a lot has to do with access to care. So we only see the patients when they're already in the advanced stage. We're not dealing with them, and that's where there needs to be attention. How to screen men for prostate cancer, or at least it's a controversial subject, prostate cancer screening, but at least to have that discussion and offer them screening.
Thank you for that discussion. That was great comments. How should patient caregiver and patient-reported outcomes be utilized, and how important do you think they are? And I'll start out with Thomas and then.
I'm sorry, when you said how could patient caregiver, you mean like someone in the home? I just want to make sure I understood the question. You don't mean
Yes.
like physicians or nurses?
No, I mean like a home giver,
like a family member.
Yes.
Well, I mean, so, with my personal take on emphasizing outcomes, I think that those outcomes are critical. And if we sort of separated them out into, there's the patient-reported clinical outcomes and then the patient-reported experiences of care. If we talk for a minute about the patient-reported clinical outcomes, I think pros and proms, these things actually provide such a window for us to get at something that David was talking about earlier, which is they can be applied across many, many conditions. We have many patient-reported outcomes that can be generic across multiple conditions, but if there are important health status indicators, we then have patient-reported outcomes that can actually be disease-specific as well. And they help us in ways that the clinical outcomes measures that we get from medical records, they just can't help us on. So if you take an example like total hips, total knees, we have typical metrics that would, if a patient were to get hospitalized, I know have shifted away from hospitalization, but let's say, just for an example, you were to hospitalize a patient to get a total hip, the measures that we would typically report on would be, 30-day mortality rates, 30-day readmission rates, infection rates in the hospital, surgical site infections and such. And none of that is really the reason the patient got their knee done, right? The reason they got their knee done is to walk up the steps and, play tennis or play with their grandchildren or whatever it is that functional thing they were hoping to achieve, or have less pain. None of those are captured in our traditional quality measures. So patient-reported outcomes have this fantastic potential, I think, to advance this field. Now, they are challenging to collect, right? By that, I mean, there's a lot of science around them, survey developers have created them for years. So that part's not a challenge. Literally, the practical implementation of them in the clinics. How do you collect them, and what time frame do you do it? I think a bunch more work and investment would be really helpful to better understand how you take what are really scientifically well-developed patient-reported outcomes and turn them into patient-reported outcome measures. Meaning how, when, and where do you collect these things? And how do we set our targets and incentive packages around them? That the space is a little bit lagging on. But again, I can't emphasize more. I believe those to be so important for the future of quality measurement.
Perfect. Thank you. David.
Yeah, I agree. I add a couple of things. First of all, with respect to the practicalities of collecting data in patient-reported outcomes, I can't speak to it in any context, but in the context of a university, one of the things we found incredibly valuable is engaging our students in that data collection. I could never have done the research studies that I've done were not for our undergraduates who volunteer or work as study students and add data collection bandwidth to our studies. And that has been invaluable. That's very expensive to do, but it's critical. And I'll also point out that although it's very tempting to think that technology is going to be the solution here, for a lot of these most vulnerable patients, technology is not necessarily always accessible. And so we've really found that's important. I also want to highlight that mixed methods approaches are very important. We've done some wonderful qualitative research that has really both inspired the design of the program and helped us evaluate it, and then patient-engaged research. Our program is constantly evolving based on the feedback from our patient and clinician advisory boards, and those sort of qualitative insights and contributions really do make a difference. So I think PROs are critical. And some of these data collection and engagement issues are key parts to that.
Great, thank you. Franklin.
Yeah, I agree with both David and Tom. The patient-reported outcomes are critical, but it's in my specialty, having done a lot of radical prostatectomy surgeries and knowing the consequences of urinary incontinence, sexual dysfunction, you have to have validated questionnaires. And in private practice, again, that's where I am, we provide the bulk of urology services across the country. Where are the infrastructure, the resources, the support to routinely measure these PROs, get the data, and then what do you do with the data? You have to assimilate the data, make it actionable. So, give it back to the provider, see how they are performing, because you may have physicians who think they've got perfect results doing surgery, but when you show them the data, it really can improve quality. But it's that infrastructure that is really lacking. And, my colleagues here fortunately have big institutions to support them. Many of us in private practice have to create this ourselves, and I'm harping on that because it's critical. I think this is where the payers and the government need to be supporting infrastructure, whether it's through NISQIP, through the American College of Surgeons, which has a great program, but you have to invest, as I understand, through expensive nurses to collect the data. And with current reimbursement, it's just impossible.
Yeah, I would just to tag on to that. This is I think our system is the largest collector of PROMs in the country. This is the most expensive measure that we collect by far. The infrastructure needed to do it is it's more than nurse chart abstractors for NSQIP or a Society for Thoracic Surgery as such. It's just expensive, but again, invaluable. Like once you have those data, they're very, very powerful to drive improvement, but very expensive.
Thank you for that. So PTAC has had a lot of discussions about how to engage specialists and had a lot of discussions about can we nest specialty bundles or specialty services within a total cost of care model in a broader network. So could you all comment about how you might structure the metrics associated with specialists within a broader clinically integrated network, and maybe in particular around the things that might traditionally otherwise be a bundle? Does that question make sense? And I'll start out with Franklin on that one.
Well, I have limited knowledge and experience how we would create a bundle, but just looking from a practical standpoint, at my colleagues, what are they treating? They're treating BPH, benign prostatic hyperplasia. They're treating prostate cancer. They're treating kidney stones, incontinence, sexual dysfunction. And we often have individual colleagues that sort of focus in one area. So as a group, perhaps we could create a bundle, but we have to, again, there's not a one size fits all. We can't paint this all with one broad brush. And I think it should start organically at the specialty level. In my case, it may not be applicable to primary care, but I think there needs to be a recognition that whether it's urology or gastroenterology, we're very different specialists. We see very different diseases. They're very different metrics. They're very different patient needs. There are some common. We've talked about equity and access, but the actual disease and the measurement and bundling and putting us at risk, it's a huge challenge from my perspective as a community practitioner.
Perfect. Thank you. Thomas?
So I think one of the, if I were to sort of break this down into like little buckets of questions that need to be answered, first I would say this is a critical area. Like we're not going to solve sort of total cost of care unless we can move solidly outside of primary care and into the specialty care space. And I don't think that I think that many of the specialty areas would be welcoming of better performance measurement. But I think we need to break it down into a couple of spaces. So one is, are we hoping to measure total cost of care across an entire system, across an entire ACO, let's say? Are we looking for total cost of care down to an individual physician? The reason that's important is because for any given episode of care, that care is often increasingly spread across many different physicians, and that's where you get sort of bogged down in like who are we assigning the bundle of care to, and then people spend a lot of time on that, right? Sort of figuring out who was the primary caregiver in this bundle of care and who do I assign it to. I think it's easier to think about it from a whole system standpoint and to say, how do we treat this hip fracture, like from start to finish? Like how much did it cost and what was our performance on it? If we want to go down to the physician level, I think we will continue to get bogged down into some of those measurement issues. The second thing that I would say is really important for us to really sort of tackle head on or just address up front is, are we talking about procedural-based care or medical-based care? We often think about bundles in terms of a procedure that is a very clear sort of time zero, and then we can measure T minus 10 days or T minus 30 days of their care, and then T plus whatever, 3 months of their care, like a hip or a knee or prostatectomy or otherwise. And what we need to also get into, because there is a lot of cost associated with it and important performance aspects, is the medical delivery of care. So I'll give you an example. A patient gets referred to a specialist because their inflammatory bowel disease or ulcerative colitis isn't getting better. And that specialist changes some of their immune therapy. When did that episode of care start? When did that bundle of care start? If we can't get better at like defining the sort of stop and start points on these things, we're going to miss a whole bunch of medical specialty care, which is a very large volume of care and expense. And increasingly, as we think about specialty pharmaceuticals that are pretty expensive but very effective in some of these conditions like inflammatory bowel disease, we're going to miss out on measuring that whole aspect of care. So my short version of that is shift some of our attention I don't know if it's away from the surgical space and into the medical space, or it's just create extra bandwidth to start looking at that medical space, because there's going to be a whole lot of cost, and it's going to be in the form of pharmaceuticals.
Great insights, and we've had a lot of discussions around that very point. So, David.
Yeah, as I mentioned in my introductory comments, one of the major areas of focus for my work has been understanding the value of medical specialization. And I think one of the real challenges we have is there's a sort of centripetal force that pulls apart medical practice. Some of that is the growth of knowledge and expertise, and some of it is the unfortunate market realities of profits being more readily available to groups that control access to a particular type of service. The former is more understandable than the latter, but I think they're both important. And I think the consequence of this in quality measurement is that we very often think about trying to find quality measures that come out of a specialty rather than encourage integration of the specialty with primary care. And there are a lot of reasons that can be valuable. Long-term follow-up of symptoms is almost certainly going to be in the primary care setting. There are contextual variables that are relevant across diseases in primary care that might be very difficult and costly for a specialty to connect. So I'd really love it if we could figure out a way to articulate the idea that quality measures should be broad and interconnected across conditions, and build an infrastructure that recognizes those synergies and encourage them.
Perfect. Thanks for the insight. And not surprisingly, we have an inflammatory bowel disease doctor that wants to ask a question. So.
Yeah, but I'm not going to ask about IBD. David, I totally agree with what you just said. But the three of you, we chose the three of you for this session because we knew you brought real world expertise to the table. And in listening to the three of you, you all have stripes on your sleeves, but you all have scars on your backs from what you've gone through in trying to succeed. And none of you are young anymore. It's taken years to accomplish what you're doing. So this committee has a voice, and in using that voice, what can the publicly funded entities like CMS do, to use a quote, to remove the on-the-ground confusion around the direction of incentive programs? If each of you had your wish list for what you wanted CMS to do, what would each of you recommend?
Start out with David.
Oh, gosh. I feel like I need about a month to really think over the answer to that. Great question. But since I don't have it, I'll just try. I think a lot about the new generation of people who are going to come in. And I think about the resources that they're going to have available to build the sorts of opportunities to learn that I've had. And I think it's a much more difficult environment for young investigators than it was before. The funding lines for K awards are not great. The funding lines for R01s are even worse. There's much less margin in academic medicine than there was before, so funding is even more important. The temptations in leadership are, more immediate sometimes, and clinical leadership, because the pressures are higher, the ability to do long-run investment. I think we are making historically damaging underinvestments in clinician investigators. We have tried to create a more competitive healthcare environment for academic medicine, which I think is great. But those resources that used to come from those margins are increasingly not available in order to produce that next generation. So I think we need to invest. And I think that investment needs to be broad-based. I mean, I'd love to see NIH's budget go up, but I would also love to see CMS's research and development budget go up. And I think with that, there also needs to be a careful understanding of the quality of the information that's generated and the type of support that's provided. I will be forever grateful to CMMI for being one of their round one innovation awards. I would have never, ever in a million years been able to do what I've done for the past decade were it not for CMMI. Those innovation awards, I think were really impactful. I honestly believe they could have been even more impactful if, the monies had been used with a little more emphasis on high quality evidence generation, but that is not a criticism of the overall endeavor. I would love to see the R&D development for Medicare increase order of magnitudes.
Thank you. Thomas?
So at least I got an extra few minutes in to think for what's a really, really hard question, but a really good question. I think the thing that comes to me for top of mind is I would really love to see CMS take on in a real way with like a very clear strategic plan how we're going to address health equity. I feel like it is the biggest public health crisis that we have right now. From an overall quality performance, health equity is going to continue to be the thing that pulls down our performance as we are not able to perform well for people who don't speak English, for lower income patients. And I don't think that I've seen, in my mind, a plan that actually sort of is on par with how big of a problem this is. And so that plan, both in terms of an investment and an urgency and a sort of a CMS sort of using its influence to push various sectors of the healthcare system. And I could go into like lots of detail around that, but I think that's like my highest level thing that I would want CMS to take on. If I were to, I'll just like if I have like two, I see I'm looking at the time here, I'll just like for 20 seconds rattle off. If CMS could push to say we are going to fund for the kinds of services that address social risk factors in a real and meaningful way, that would also push the commercial payers to also go in that direction for things that, to David's point around the evidence, that we have evidence in many ways, but we can't get payers to pay for them. If CMS could push electronic health record vendors to go in directions of development that actually support care for underserved populations, which doesn't happen right now, right? It's always an afterthought. If CMS could push in the space of really sort of language access, I think that that's going to be critical for equity. And I mean, really push hard on all these different sectors of the healthcare system.
Perfect. Thank you. And Franklin.
Thanks. I was excited when MACRA was legislated and approved I think it was 2015. And I said, here we're going to get a system that promotes quality. And 9 years later, when I see what my colleagues are reporting, I think it's really disappointing. So even though we're a small specialty and there are probably other small specialties like gastroenterology, I think there needs to be more inclusion and universal approach to whatever the metrics, the approach, but get all physicians involved. I just think a lot of us have been left out, particularly in the community practice. And I think the government needs to coordinate with the payers to make a real effort to come up with programs that are across different payers. This was our struggle. We only could get one payer to participate, and that's why the pilot, had to be concluded last year. And I just would lastly ask for the government to recognize how complicated, and it was mentioned, the cost of reporting from Health Affairs, $40,000 per patient, per physician per year, was in one of the earlier presentations this morning. We cannot absorb these costs. The cost of to develop the infrastructure, and it's there. And you heard one of the comments on the EHR. There needs to be coordination, collaboration between EHR companies to get structured data fields, to pull out the data in structured mechanisms. There's a tremendous infrastructure that needs to be invested in. And particularly as I speak from the community practice world, we need help. Thank you.
Thank you for that. And I want to thank all the presenters for a great session this afternoon. And, You all are welcome to stay on and listen as much of the meeting as you would like to. We're now going to take a 10-minute break until 2:40 p.m. Eastern Time before moving on to our next listening session, where we'll hear from experts on selecting and designing measures for total cost of care models. So thank you. We'll move to our break.
Produced by the U.S. Department of Health and Human Services.